Okay, today we're going to cover part 2 of the cardiovascular diseases discussed in Advanced Medical Emergencies. You also have this in further detail when you get into your cardiology course in the fall. First, let's discuss thoracic and abdominal aortic aneurysms. As I've told you before, the aneurysm is a vessel that's dilated and blood collects, and that forms the aneurysm. Multiple causes are possible. This includes atherosclerotic disease or heart disease, infection, and one of the primary causes of this is actually the infectious disease of syphilis, traumatic injuries, and then certain genetic disorders. And the biggest example of that is Marfan syndrome. If you will refer to your Bates text, which is your green book for 210, you can actually find very good descriptions of the process of syphilis and also of Marfan syndrome. So what happens when an aneurysm deforms? We have that weak point in the wall that results in degenerative changes in the layers of the wall vessel, which allows pressure to increase. Over time, this pressure gets larger and larger and larger and increases to the point where it can actually rupture. Abdominal aortic aneurysm is one I talked about a lot in class. It affects approximately 2% of the population. Most commonly, the sites that it occurs at is below the renal arteries or above the point where the iliac arteries bifurcate. It's more common in men, so always think about your male patients greater than 50 years of age with unexplained chest and back pain and differences of 15 to 25 millimeters of mercury in their systolic blood pressures between the two arms, who are also between the ages of 60 and 70. It's also a good time to get a history and find out if there's any siblings or first-degree relatives who have had these type of events or diagnoses in the past. Most of the time, patients have aneurysms and they are actually asymptomatic until their aneurysm begins to expand or to leak. And a lot of the times, their symptoms are due to that blood leakage, which causes the inflammation such as peritonitis. What happens when it ruptures? The tear expands. It can cause bleeding, which goes in the retroperitoneal space, which is why they have that significant, sharp, tearing back pain. They also can have a point to where the bleeding can get to the point to where it can actually tamponade itself, which tamponading at that point means that the blood's not leaking until the pressure gets high enough, and at that point they can actually completely tear open and have massive fatal hemorrhage. As blood loss occurs, you can imagine we have all the blood that's being pumped through the lower portion of the body going out of a defect in the wall, which is the aneurysm of the abdominal aorta, and the patient develops hypovolemic shock. Frequently is a cause of syncope, and this is a key point to remember. Syncope followed by hypotension with bradycardia. If you'll remember back to your definitions of orthostatic vitals, a lot of times a patient who has syncope, they do have that hypotension, but they're going to have a period tachycardia also, and these patients have that bradycardia that can be sustained. So signs and symptoms: unexplained hypotension, unexplained syncope, sudden onset of abdominal or back pain. Usually the patient with a aortic aneurysm, their pain doesn't gradually get worse with the leakage or the rupture. It's very intensive, sudden onset of massive pain. They'll have signs of peritoneal irritation, a lot of abdominal pain, maybe guarding, some rigidity can be present. They have that urge to defecate, and that's caused by the pressure from the blood leaking into the retroperitoneal space. Pulsatile tender mass. So as we learn with our abdominal assessments that we see we can palpate a pulsating mass, we should be able to palpate the abdominal aorta pulse, but not necessarily a mass. And then distal pulses that may be present or may be absent. You may have differing pulses, you may have weakened, you may have irregular pulses. So you can really have the entire gamut of the pulse, normal situations and abnormal situations. GI bleeding, and then if they do have that pulsatile mass, we don't want to palpate it anymore. So one of the techniques we can use is actually auscultation. And when we auscultate that area, we may hear what sounds like a murmur, which is basically like an extra flow sound, an extra flow sound in the lub-dub. So we have an extra sound to our lub-dub like we would with a heartbeat, or a bruit, which is kind of like a whooshing sound as the blood's flowing through. How do we manage it? Well, like I've talked about before, we, as pre-hospital care providers, can't truly manage an aneurysm that's leaking or ruptured. Our biggest goal is rapid transport to a definitive care facility. So operation is repair of that vessel is the definitive treatment. 20% of aneurysms, they actually rupture before reaching the hospital, because remember, your patients may be asymptomatic, and whenever that leak starts to occur is when they have the symptoms, and as it progresses, then they can tend to call 911. The 80% of those patients that have that rupture happen die. We want to handle them gently. We don't want to do anything to basically contribute to further tearing of the vessel. Place them on oxygen, cardiac monitor, IV fluids. Our main goal for IV fluids at the point when they are able to sustain their own pressure is to help to keep them normotensive, kind of like you think about your traumatic hemorrhagic stroke patients. Hemorrhage patients. And then if we have complete rupture and we have the loss of pulses, significant hypotension, then we're going to give them vast amounts of fluid volume. And then let your receiving facility know what type of signs and symptoms you're seeing. As I said before, you can actually keep them mildly hypotensive because you don't want to cause a further rupture if it's just leaking at that point. And then if it's ruptured, then we may need to progress to aggressive fluids resuscitation. If you have a rupture, you will see hypotension, tachycardia, loss of pulsating mass, and unresponsive in your patient. A lot of times they will go into cardiac arrest. It requires rapid and aggressive resuscitation. The acute dissecting aortic aneurysm, so this is the aorta of your heart, is 3 times as common as a ruptured abdominal aortic aneurysm. So what is that? What is some factors that can lead to hypertension? I've talked to you about this before. Hypertension that is uncontrolled and that its control is not maintained is a significant factor. Atherosclerosis, congenital abnormalities, changes in the connective tissue, trauma, pregnancy. It affects 2 times as many men as women and is also more common in African Americans. What causes it is a small tear in the intimal layer of the vessel wall. After that tear occurs, then we have dissection, which creates a false passage which forms a hematoma, and that hematoma can rupture at any time. Most cases it's in the ascending aorta, but it can extend to involve the thoracic, abdominal tributaries, coronary arteries, aortic valve, carotid, and subclavian vessels. So it can be very, very large and far-reaching. Some results: syncope, stroke, absent or reduced pulses, heart failure, pericardial tamponade, and an MI. More than 70% of these patients complain of back pain, epigastric pain, abdominal pain, or actually extremity pain. If you think about it, we're looking at the level of the heart, and everything below is compromised in its amount of flow. It's a sudden onset with that sharp, ripping, tearing sensation. They describe it as cuts like a knife. It usually actually starts in between the scapula and can extend all the way down into the legs. The patient can look shocky. Think about it, they're bleeding out, so they will look shocky. They can have elevated or normal blood pressure for a period of time. And then their blood pressure can definitely significantly differ in the 2 arms. Remember, you want to look at that 15 to 25 millimeters of mercury range of your systolic pressures. So get in the habits now of doing blood pressures on your patient's arms. Distinctive features is the pain is maximal from the onset. Usually your MI pain tends to escalate as the injury occurs, but this type of pain is very maximum from the onset. It travels downward as the dissection progresses. We have once again that differences in blood pressure. Peripheral pulses tend to be unequal too, so you may have a good carotid or radial on your right and not on your left. Your patient can also have neurological deficits because now the cerebral vessels are not getting the blood and oxygenation that it needs to from this. Goals are for pain relief, so we want to do analgesics, so your morphine is definitely, as long as you have the other criteria to administer morphine, is definitely a do not delay transports on these patients. Handle them gently like I talked about before. Be ready to intubate, take over airway, and assist with ventilations. Remember, respiratory and cardiac arrest can commonly occur. And then get your IVs in them, but keep fluids to them. Next, we're going on to acute arterial occlusions. And that is a sudden blockage of arterial flow. It's usually caused by trauma, emboli, or thrombosis. The severity depends on the location and the amount of collateral circulation around the blockage. So collateral circulation is circulation that the body has created as this occlusion has been forming. It's basically created surrounding circulation in order to allow blood to continue to flow. Vascular occlusion is caused by a thrombosis. It's a complication of an atherosclerosis or a type of heart disease. And then occlusion secondary to emboli may indicate a disturbance in the cardiac rhythm. Trauma occlusions, we've talked about this before. Long bone fractures is a significant risk factor, and it's usually evident from decreased circulation to the injury. Embolus occurs when the blood clot breaks away and enters the arterial system, travels till it reaches a narrowed point. Patient with a history of heart disease favors embolic diagnosis, and there's many, basically your extremity arteries are your. Thrombosis occurs at sites of vessel stenosis. Usually occurs gradually over time. Location of pain is related to the site of the occlusion. And if ischemia persists, you have necrosis that develops, most often seen in men, smokers, and those over 60 years of age. Signs and symptoms: severe sudden onset of pain, pallor or cyanosis or mottling to the extremity or the affected area, lowered skin temperature to the extremity or the affected area, changes in sensory and motor function, diminished or absent pulses. Remember, this is blocking an area where no or very significantly decreased flow is occurring below that site. You can have a bruit over the affected vessel, slow capillary filling, shock, and then systolic blood pressure readings of greater than 15 or more. Occlusion is serious and limb can be threatening to the limb's life. Immobilize and protect the affected part, so we want to handle it gently. Basically considered soft splitting it. Transport, treat for shock, and analgesics for. Other conditions are varicose veins, superficial thrombophlebitis, and acute deep vein thrombosis. So any patient who has a history of trauma, sepsis, stasis, inactivity, pregnancy, birth control pill use, malignancies, smoking, or varicose veins are at risk. DVT is the most serious problem that we want to talk about. More common in your lower extremities. You have multiple risk factors as is listed. And a lot of these we've talked about multiple times in the past. So this patient has pain, edema, and warmth. The key factor there is that warmth, because they're also either red or blue from decreased circulation, but they're hot to the touch, and tenderness, severe tenderness. So once again, you may actually want to elevate the extremity, palpate those pulses. If you can't palpate them, have someone else check behind you. And then also, if you have option for a Doppler, Some EMS services actually will carry a Doppler, which is mainly used to detect fetal heart tones, but this is a great place to use it to see if you can palpate and use Doppler to see if you can find that pulse. And these patients don't typically get surgery as much as diagnosis, bed rest, and they'll get anticoagulant therapy, sometimes by IV, sometimes by pill for several days in the hospital to treat. Hypertension is something that we deal with very heavily in the United States. It's 23% of our population is diagnosed with hypertension, and I'm sure there's another significant portion that's undiagnosed. It's responsible for approximately 23,000 deaths a year. Now, about 6 years ago, that was 13,000 deaths. So we are still not cutting down on the levels of hypertension that's occurring in the United States. And as our obesity epidemic continues to worsen, I think we will also continue to have greater increases in this disease. Typically, the diagnosis of this is a blood pressure that's been sustained at greater than 140/90. The most common cause, the most common cause is noncompliance with medicine. It's kind of like seizures. The most common cause of seizures in an adult is noncompliance with medicine. Same thing for hypertension, it's noncompliance with medicine. Chronic hypertension requires the heart to work more than normal, leads to cardiac muscle hypertrophy, and your left ventricular failure. So once again, go back and think about what you see in a patient who develops LVF. Other conditions that are associated with this cerebral hemorrhage, stroke, MI, renal failure, and then develop of aneurysms. Many patients have elevated cardiac output and elevated peripheral. So what do we do for our patients with hypertension? Well, our biggest concern for pre-hospital treatment is with the extreme hypertensions. But we have that patient, we want to try as best as we can to stabilize them, because if they have pulmonary edema, aortic aneurysms, toxemia, pregnancy, and stroke, that hypertension exacerbates the problem. So normally if we can treat the problem such as pulmonary edema, remember your pulmonary edema patients have hypertension. So if we're able to treat the pulmonary edema, we may actually negate the hypertension. Same thing with toxemia pregnancies. Your preeclampsia patients, you treat that preeclampsia, you get the blood pressure lowered, and hopefully you prevent them from going into eclampsia. So sometimes it's not as easily to control the condition, and you may have to control the blood pressure primarily first. So the biggest end result of hypertension that's uncontrolled is that end organ damage. So your most likely organs at risk are brain, heart, and the kidneys, and that causes irreversible damage to those organs. If we are in a hypertensive emergent state, our goal is to decrease that blood pressure by 5 to 20% within a few hours, or else it will lead to permanent organ damage. Like I said earlier, there's different causes that lead to hypertension, and these are a list of them. So what does our hypertensive emergencies look like? They can have that P&D, shortness of breath, altered mental status. Think about what's going on physiologically with this patient. Vertigo, headache. So you want to be careful with your headache patients about just brush them off and saying this is just a classic headache, why are they calling me? Epistaxis. If you go back and look at the state protocol for epistaxis, which is the nosebleed, the main treatment to stop the nosebleed is Afrin, which is try to remember what type that is of drug, but it basically is a potent vasoconstrictor. So if we have a patient who's hypertension, that's one of the key things we have to check before we administer the nose spray, is that they aren't hypertensive. If so, it's contraindicated. Tinnitus, changes in visual acuity, nausea and vomiting, seizure, and then ECG changes. Major emergency is hypertensive encephalopathy. That's basically the point to where hypertension has led to fluid being exuded into brain tissue. It can progress over several hours. It requires transport to a medical care facility for definitive care. We want to lower the blood pressure. We want to lower the blood pressure rapidly, but in a controlled manner. Because if we lower it too fast, we can still cause infarction of the end organs. So, do your typical ALS care of your patients, and then depending on the protocol, you'll most likely you may administer nitroglycerin spray or tablets to help with that, lower the blood pressure. And then the most common secondary administration is a beta blocker. Now there's criteria for that, so I want you guys to go onto the website for EMS and look up the newest hypertensive emergency protocols. You need to learn what the criteria is for beta blocker administration in the field. Next topic is specific heart diseases such as valvular, infectious, and cardiomyopathy. This is just kind of an FYI section. You will more heavily go through this in cardiology, so you're getting your first exposure to this. Valvular heart disease is basically what it sounds like. Valvular heart disease is any disease process that affects your heart valves. Your most common ones that are affected is your mitral and your aortic valve. So two main conditions can occur. We have stenosis, which is due to narrowing, hardening, or thickening of the valves, which does not allow them to open or close completely. And then we also have incompetent valves, so they're kind of floppy. If you want to think about hard, not mobile valves, and then kind of floppy valves, which allows blood to flow backward. It can result in loss of elasticity, increased risk of pulmonary embolism, or stroke. Signs and symptoms are similar to heart failure. Think about heart failure. We have failure of the atria and the ventricles to properly eject blood into its proper locations. But this time, between the atria and the ventricles, the aortic and the pulmonic, we have failure for it to completely allow the flow to occur. So your patient's fatigue, palpitations with or without chest pain, dizziness, weight gain, and there's also bacterial causes, which we'll discuss in just a moment, so your patient may actually have a fever. Mainly our pre-hospital care is supportive. That's why it's important for you to listen to those heart valves on your normal assessments, because you a lot of times can notice a different sound with these type of patients, which we will discuss in greater detail in 210. Infectious heart disease is what it sounds like. Something has infected the heart, some type of pathogen. It can cause muscle and valve damage. It can also cause emboli that will travel to the brain, the kidney, lungs, or abdomens. There's three common forms, and they're named by their location in the heart, or the heart layers: endocarditis, pericarditis, and myocarditis. Endocarditis is infection in the endocardium. Patients with IV drug use, ones who've had permanent central venous access placements, previous valve surgery, recent dental surgery, and rheumatic fever are at risk. Multiple complications. Strep is responsible for about 50% of all cases. So we have a lot of things that strep is responsible for, and this is one. Multiple signs and symptoms. Think about you have a patient who has cardiac disease with pain and also has an infection, so they have the signs and symptoms of all three of those at the same time. They'll also have different types of splinter hemorrhages, Janeway lesions, Osler nodes, and I want you to look those up in your 210 book for your definitions, and we will discuss them at a later time. Pericarditis is inflammation. It's usually due to some type of virus. Most commonly affects men greater than 50 years of age and children who have suffered a recent respiratory infection. It's associated with your autoimmune disorders, HIV or AIDS, hypothyroidism, rheumatic fever, and TB. Also can be due to trauma, immune suppressing medications, myocarditis, and patients who are receiving radiation therapy to the chest. These patients have a lot of pain, especially with deep breathing, and that should be lying flat, not flying flat. Just caught that. Dry cough. So they don't have the signs and symptoms of, say, pneumonia, where they have productive cough. They have a dry, hacking cough, fatigue, and fever. Myocarditis is inflammation of the heart muscle itself. The chest pain for these patients is severe. They can also have joint pain or swelling in output. And then last but not least is cardiomyopathy. Just basically, there's 3 types: dilated, restrictive, and hypertrophic. Your dilated is the most common type. It's when the heart muscle becomes weakened and enlarged so it can't pump efficiently. It's usually due to some type of medical problem. Your restrictive is where the heart chambers are unable to properly fill because of stiffness of the heart, so you have a stiff heart. The most common cause is amyloidosis, I'll try to say that right, and that's a condition where the body actually deposits abnormal amounts of protein on the heart tissue, which leads to the stiffness and decreased compliance of the heart. And it's commonly a situation that occurs after heart transplants. Then your third type is hypertrophic, which is where the heart muscle becomes thicker than other parts, so it makes it more difficult for blood to leave the heart. It's an inherited type of cardiomyopathy. Most commonly you see this is the young athletic patient who appears to be in perfect health, is in the middle of a game or practice, collapses on the field, goes into sudden cardiac death, and dies. So it's because it's got that inherited factor. It is not something that's commonly examined for, and until they hit a reason to create this dysrhythmia, there's typically no signs and symptoms of it. In general, your patients have breathlessness, edema, even abdominal edema, fatigue, lightheadedness, fainting, and dizziness.